I once had a charge nurse who'd end our morning huddles, especially on the days when we were short staffed or the ER was slammed, with the simple line, "Let's be dynamic and flexible today." He would say with half a smile, but we all knew what it meant. It meant brace yourself, it's gonna be a rough day today. In the ER, you never know what kind of day you're walking into or what kind of patient is about to roll through the doors. So, with that in mind, let's go over 7 diverse practice questions designed to test your knowledge, build your confidence, and as he used to say, help you stay flexible and dynamic. So, we are doing a question on DKA, on sedation for intubated patients, on vasopressors, a question on congestive heart failure, hypoglycemia, seizures, and heparin infusions. Let's get started. So let's jump into question number 1. You have a DKA patient who just came in with signs again pointing towards DKA. Blood sugar is 800, they're pale, they're dry, breathing heavily in a Kussmaul pattern, and vomiting. They've been off insulin for a week and recently went on a binge with alcohol. They're already getting a 3-liter bolus of normal saline. Now, the chemistry came back. The bicarb is 11, the chloride is 99, the sodium is 139, and most importantly, the potassium is 2.9. Here's the question. If an insulin infusion was ordered right now at this point with this result, would you start it? Pause and think about it. What's the risk if you did? Again, if an insulin infusion was ordered right now with these results, would you start it? The answer here is no. You should not start the insulin infusion yet. Even though the patient is clearly in DKA, the potassium is too low at 2.9. Insulin drives potassium into cells, and if the serum potassium is already low, giving insulin can make it even lower, and that's dangerous. Critically low potassium can lead to life-threatening arrhythmias, and we're trying to save this patient, not push them into a code by bringing their potassium lower. So what can we do instead? What do we do instead? We hold the insulin, we replace the potassium first, and then we recheck the level. Once it's above the 3.3, then we can safely begin the insulin infusion. Again, each hospital has its own protocol, but most follow that 3.3 cutoff. Just always double check what your facility's policy is. But the key concept is going to be don't drop potassium even further with insulin. Fix it first, replace it. If it's less than 3.3, you should not be starting the insulin infusion because you will drop the potassium too low, and that's dangerous because it can lead to life-threatening arrhythmias. Now, let's move on to question number 2. You have a patient who came in with stroke-like symptoms and significantly decreased mental status. They have a left-sided facial droop, minimal response to pain on the left side, and they're not following commands. Their verbal output is incomprehensible and they required repeated stimulation just to stay awake. On exam, their GCS is 8, that's E2, V2, and M4. And due to their altered mental status and episodes of vomiting, they were intubated to protect their airway. A CT confirms a brain bleed. Now that they're intubated, you need to start sedation for this patient. So here's the question. Which medication is the best option for this specific situation and why? Again, this patient, stroke-like symptoms, was intubated because of their altered mental status and was vomiting, and then CT confirmed a brain bleed for this patient. Which medication is the best option for sedation for this mechanically ventilated patient? Think through the common choices like midazolam, propofol, and even Precedex. Which would be the best option for this situation? The best sedation choice in this case is going to be propofol. Why? Because the patient just had a newly discovered brain bleed, and neurosurgery will likely want to monitor changes or recheck a neural status soon so they can get their own baseline neural assessment. Propofol is ideal here because of its rapid onset and short half-life. If you need to pause sedation, pause the propofol for a neural check or surgical evaluation, its effects typically wear off in 10 to 15 minutes. That's exactly what you want in a critical neural patient: control and flexibility. You want to be able to turn off sedation and for you to almost immediately, or at least very soon, be able to get a good, accurate neural assessment. Plus, brain bleeds often come with a blood pressure goal of less than 140 systolic, and propofol, due to its properties, can help bring down the blood pressure. But there's a balance. If you drop the blood pressure too far for these patients, you run the risk of reducing cerebral perfusion, which can make things worse. That's why it's going to be important to titrate slowly and stay within the ordered blood pressure parameters. Compared to midazolam, which can linger and delay neurochecks, or Precedex, which may not provide deep enough sedation, propofol gives you quick, controllable sedation that supports both neural monitoring and BP management. Now, let's take a look at question number 3. You're caring for a patient in septic shock, and the suspected source is a septic renal stone. They've already been appropriately resuscitated. They received their full 38 ml per kilograms of IV fluid, and antibiotics are also on board. Despite all that, the patient's blood pressure is still low at 86/42, and the lactate is elevated at 6.5, which tells you that this patient still has poor perfusion. Their other vital signs are a heart rate of 110, respiratory rate of 26, temperature of 100, and SpO2 of 94% on room air. You notify the provider, and they mention they're likely going to start a vasopressor. So here's your question. Which vasopressor do you expect them to order, and why do you expect that one in particular? Pause here and think it through. What's the first line pressor for septic shock? What do you want to improve, and what do you want to avoid? The correct vasopressor here is norepinephrine, also commonly known as Levophed. This is the first line vasopressor for septic shock, especially when the patient has already received adequate fluid resuscitation but remains hypotensive. Norepinephrine works primarily through alpha-1 receptor stimulation, which causes vasoconstriction and increases vascular tone, helping raise the mean arterial pressure, or MAP. That means better perfusion to vital organs, exactly what we need for this patient with a high lactate and low blood pressure. One of the advantages of norepinephrine is that it doesn't significantly raise the heart rate, which is helpful here since the patient is already tachycardic at 110 beats per minute. It's typically titrated to maintain a MAP of 65 or greater, though that goal can vary based on the patient or provider preferences. But again, typically titrated to maintain a MAP of 65 or greater. While norepinephrine improves perfusion, it's still critical to monitor for its effectiveness. Keep an eye on urine output, mental status, cap refill, and skin color. You combine it with an improving blood pressure and MAP, and these give you real-time clues to whether the patient is truly improving. Remember, you want to combine what you're seeing as far as the MAP, the blood pressure, with what the patient is actually doing. Now, let's go into question number 4. You have a patient presenting with shortness of breath and increased work of breathing that's been worsening over the last week. On assessment, they're speaking only 1 to 2 word sentences, and they say they feel like they're drowning, which should immediately get your attention. You auscultate crackles in the lower lung field, and they have +4 pitting edema in both legs. EMS tells you that the family reported a history of congestive heart failure and hypertension, but the patient hasn't taken their medications for over 3 weeks due to running out. Your provider suspects a CHF exacerbation. So here's your question. What are the most important and effective treatments you should anticipate for an acute CHF exacerbation, and why? Think about what's causing this, what's causing those symptoms, and what will relieve both the fluid overload and the respiratory distress. In a CHF exacerbation, your top priorities are to improve oxygenation and reduce the heart's workload quickly, right? This patient is in respiratory distress, speaking in 1 to 2 word sentences, and they're feeling like they're drowning, so immediate action is critical. The first line interventions are going to be BiPAP and nitroglycerin. BiPAP delivers positive pressure, which helps push fluid out of the alveoli, improves oxygenation, and reduces work of breathing. At the same time, nitroglycerin can be administered. Typically, these patients are going to be very hypertensive, which is why nitroglycerin can be given and is indicated. Of course, if the patient is hypotensive, you're not going to be giving nitroglycerin because it brings down blood pressure. Now, for this patient who is hypertensive as a result of fluid overload, we're going to give it because it causes venous and arterial vasodilation, which reduces preload and afterload, taking strain off the heart. But just as importantly in this context, nitroglycerin dilates the pulmonary vessels, which lowers pulmonary capillary pressures. That allows some of the fluid that's filled the lungs to shift back into circulation, helping the lungs clear faster. After you've supported breathing and the ease of the strain on the heart, you're going to be given furosemide, Lasix, to pull off that fluid. While it's essential, Lasix does take time to work. So it's given very shortly after or pretty much alongside the initial interventions. So altogether, BiPAP, nitroglycerin, and Lasix work in synergy, oxygenation support, reduce pressure and strain, and remove the excess volume. Now, let's move on to question number 5. A patient presents with altered mental status, and your initial point of care glucose shows a low blood sugar of 40. EMS reports that family saw him taking his insulin this morning, but then he got sidetracked and never ended up eating. So, this is a classic case of insulin-induced hypoglycemia. Now, the patient is symptomatic and altered, which means we can't rely on oral intake. The question for this patient is going to be, what are the steps you should take to treat hypoglycemia in this setting? Think about what route is appropriate, what medication or solution you should give, and what comes next after the initial intervention. And if you're watching the video, sorry, I apologize that the rest of the slide is not loading on screen. But again, the question is, what are the steps you should take to treat hypoglycemia in this setting? The first and most important thing to recognize here is that oral glucose is not going to be appropriate. This patient is altered, and giving anything by mouth when a patient can't protect their airway puts them at a serious risk of aspiration. So no juice, no glucose gel, nothing by mouth, even if it's tempting. Instead, the immediate treatment is to give an amp of dextrose, usually D50, through an IV. This delivers a quick, concentrated dose of glucose directly into the bloodstream and typically results in a noticeable improvement in mental status within minutes. But what if you can't get IV access after a couple of attempts or it's taking too long? What's the next step? The next move is to give glucagon intramuscularly. It stimulates the liver to release stored glucose, but it takes longer to work than IV dextrose and may not be as effective in malnourished or liver-compromised patients. After giving the dextrose, it's critical to recheck the glucose regularly, usually every 15 minutes at first, and watch for improvement in mental status. If it remains low, additional amps should be given, and the patient may have to be started on an infusion containing dextrose. Once the patient is awake and alert enough, then you should encourage them to eat to prevent the sugar from crashing again, especially if they still have insulin on board. Now, let's go on to question number 6, treating a patient who is actively seizing. When it comes to seizures, benzodiazepines are the first line medications. They work by enhancing GABA, a calming neurotransmitter which helps suppress abnormal electrical activity in the brain. Quick treatment is crucial to stop the seizure and prevent brain injury or progression to status epilepticus. But as always, in emergency care, the route matters. If the patient is actively seizing, they may be difficult to start an IV on. You need to act fast. So this raises the question, which benzodiazepine is best when there's no IV access? And which one is preferred when an IV is available? Think through the different benzos that we use in the ER, like midazolam and lorazepam, and what makes each one ideal in different routes and scenarios. So, the right benzodiazepine depends on whether you have IV access or not. If the patient is actively seizing and you don't have IV access, the best option is midazolam, given intramuscularly. Why? Because it's fast acting, easy to administer, and doesn't require you to get a line, which is often difficult or unsafe during an active seizure. On the other hand, if IV access is already in place, the preferred medication is lorazepam or Ativan, otherwise known as Ativan IV. It may not be quite as fast as midazolam, but it has a longer duration of action, which helps reduce the risk of the seizure recurring. The key point is don't delay treatment trying to get IV access. Time is brain. If the seizure is ongoing and there's no IV, go straight for midazolam intramuscularly. If it's effective, safe, and often used by EMS and ER teams in the field for this reason. Once the medication is given, monitor for airway issues, check for seizure resolution, and be ready to support breathing if needed in that post-ictal state. Now, let's move on to question number 7, heparin drips. Heparin infusions are something you'll see often in the ER, especially for conditions like NSTEMIs, pulmonary embolisms, and DVTs. As the bedside nurse, you'll not only start the infusion, but you'll also be managing it closely. But before you can safely start a heparin drip, there are a few critical baseline labs and safety checks that must be done beforehand. These are essential to avoid serious complications like bleeding or heparin-induced thrombocytopenia. So here's the question. Before starting the infusion, what key labs and assessments must be obtained? Also, think about the setup. What should be in place IV-wise to prevent any delays or complications later on? Pause here and think about what helps you monitor for bleeding, what confirms the patient is safe to receive anticoagulation, and what you'd want ready before the drip starts. So, before starting a heparin infusion, your job is to make sure the patient is safe to receive it, and that starts with getting the right baseline labs and setup. First, you need a baseline APTT because this is the lab that will be used to monitor and adjust the heparin infusion based on the protocol that the provider ordered. Starting without it means you won't know where the patient's coagulation level is or how the medication is going to affect them. So you want to get a baseline level first. Next, check the hemoglobin and hematocrit. This helps you identify any hidden or ongoing bleeding, especially in patients who are already asymptomatic or have GI bleeding risks. Don't forget the platelet count. If you need to make sure the patient isn't already thrombocytopenic and doesn't have a history of heparin-induced thrombocytopenia. If platelets are low to begin with, heparin could worsen the situation significantly. If there's any concern for GI bleeding or if they're high risk, you may also see stool or urine samples ordered to check for occult blood. Another step to ensure there's no bleeding risk before starting. Lastly, from a setup perspective, make sure the patient has 2 good IV lines. Once the heparin drip starts, you want to avoid poking them for more access, not just because of discomfort, but also to reduce bleeding risk and ensure uninterrupted access for labs or medications. These steps help that when the heparin drip starts, you're not just following orders, you're thinking ahead, protecting the patient, and setting yourself up for safe, smooth care. By the way, I created a book and a course to help you save time and energy with mastering the chaos of the ER. They're packed with everything you need, including emergency fundamentals, practice questions, real scenarios, charting essentials, and practical tips to help you feel confident and prepared in the ER. You'll find the links in the pinned comment and description below. Just remember to review and look up things outside of work, especially when you're new. By doing this, combined with asking questions and learning from others, you're going to build your foundation of ER knowledge little by little, and eventually you'll get to the point where you are confident in yourself and in your abilities. Again, be easy on yourself. It takes 6 months to a year to start feeling remotely any sense of confidence, and it can take up to even 2 years. But as long as you're building your knowledge base little by little and reviewing and constantly asking questions, that will occur. Remember, the more you know, the safer an ER nurse you are. So be curious and continue your learning. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.